Good day, friends, and a warm welcome to the 40th episode of 4D, that is, Detailed Discussion and Dialogue in Indian Diabetes. 4D is a very dynamic, a very daring platform. It's dynamic because we have the latest in diabetes care. It's daring because we don't feel shy of exploring things that are not written in the textbook. And all our experts, what they bring to us is a very beautiful combination, a duologue of eminence and experience. That's what they come with. And then evidence from trials, from research. We have a similar speaker today, someone who is endowed with a lot of experience and with eminence and who knows the evidence. A warm welcome, Dr. Nikit Khadakwal.
Thank you, sir, for your kind introduction. Uh, I am Dr. Nihit Karkwar, and I am an assistant professor in KGMC Lucknow. Today's,
Dr. Nihit has a very
can I?
rich academic career, yes, behind him. Uh, MBBS from the prestigious KGMU in Lucknow, and then an MD in pediatrics from New Delhi, and then DM in endocrinology from Meerut. And now he is back in Lucknow. He also has experience of living in and working in multiple states, UP and Delhi, of course, and also Uttarakhand. So, Dr. Nihit, uh, how easy is it to practice diabetes?
Sir, first of all, my MD is in pediatrics, so it was a little bit challenging for me to deal with adult patients. But as I comes to know how we can deal with adult patient, how diabetes can be approached, how the pathogenesis of diabetes, what is the pathogenesis of diabetes, and it will get easy to deal with the patients of diabetes and with the experience of all the physicians that are in training process, there are those who have trained in endocrinology that they can deal easily with the diabetic patient.
Now, the maximum improvement in life expectancy, of course, everybody has worked hard in the country, all the physicians, all the nurses, but it is said that the maximum improvement in life expectancy is because of our Asha workers, because they focus on prevention of disease. And this is led by the pediatrics community, prevention of disease. In endocrinology, also, we have a rich history, and the Kangra Valley study, where they found out that iodized salt actually reduces goiter, reduces iodine deficiency disorders, that led to huge changes in public health planning and practices. And that's why we are a healthier and more intelligent country now. So, Dr. Nihit, would you like to speak today about prevention of diabetes, prevention of metabolic syndrome, and the best practices that have been used so successfully by people in public health and in pediatrics? Can we bring the same thought process to endocrinology and diabetes care?
Yes, yes, definitely, sir. Actually, uh, as all we know that prevention is better than the cure. So we should first we should try to prevent the any complication, any disease process of diabetes and metabolic syndrome. So here we are to talk about something about prevention and treatment of diabetes and something about metabolic syndrome. So that
Sure. Carry on, Dr. Nihit.
can can we can we start? So here we are here to discuss something about prevention of diabetes and how can we manage pre-diabetes and diabetes and something about metabolic syndrome and what are the uh, points that are related to metabolic syndrome and how can we proceed to prevent these pathological conditions. Next slide. Now let's talk about some demographic data of diabetes in India. As we all know that diabetes is rapidly progressing all over the world, especially in India, the situation is very grave. In India, about 1 in 11 adults is living with diabetes. If we talk about latest recent data, then we can see that 90 million adults are having diabetes in India. And the sad part is over 53.1% of the adults in India are undiagnosed. They don't know that they are having diabetes or diabetic complications. Uh, in this way, we can say that 1 in 2 adults are unaware of their pathogenesis, that they are having actually diabetes. And because of these factors, India is leading country uh, to having a diabetic patient, and India holds second position in world if we talk about diabetic patients. Not only morbidity but mortality is very high in diabetes patient because of its complications like kidney failure, liver failure, or heart failure. And according to recent data, around 700,000 deaths have been occurred in India in 2021 because of diabetes or its complications. As far as impaired glucose tolerance is concerned, around 40 million adults are in India that are having impaired glucose tolerance. And because of this, the risk of uh, developing type 2 diabetes is very high in Indian population. Next slide. Now, for something about metabolic syndrome. Metabolic syndrome is a syndrome comprising of mainly five factors, that is insulin resistance, visceral obesity, hypertension, high triglyceride level, and low HDL cholesterol. Diabetes is an important component of metabolic syndrome. As diabetes is very common in Indian people, so far metabolic syndrome is also very common in Indian or South Asian people because of their sedentary lifestyle, their junk food behavior, and their stressful conditions. In India, around 99 to 48% is prevalence has been documented for metabolic syndrome. And uh, diabetes and metabolic syndrome goes hand by hand. Next slide. Next slide, please. Now, if we talk about risk factors of diabetes or metabolic syndrome, the first risk factor that is very important for the development of metabolic syndrome is sedentary lifestyle. Why India is having sedentary lifestyle mechanism? Because as we all know that India is a fastest growing economies in the world, and this country is currently undergoing rapid transition with increased urbanization through the country. And because of this urbanization, there is a huge transition from uh, a good lifestyle to a bad lifestyle, including junk food behavior, including a sedentary lifestyle, including a stressful condition, and pollution, and multiple endocrine disruptor factors that have uh, badly that has a bad impact on a metabolic on our metabolism in day-to-day life. If we talk about the rate of urbanization, then we can say that in 1950, the rate of urbanization was around 8%, which has increased from 8% to 35% in 2021. Studies have proved that this type of socioeconomic development has caused a bad impact on our physical activities, has caused a bad impact on our day-to-day life. And because of this technological advancement, we are prone to have a junk food diet. We are prone to have stressful condition, and we are getting high sugar, high fat, high calories in our diet. And these all factors leads to the development of metabolic syndrome and diabetes. This obesity and sedentary lifestyle are important risk factors for the disruption of the insulin resistance, for the disruption of insulin production, and for the development of insulin resistance, which ultimately leads to the production of diabetes. That is why diabetes are more common in urban residents as compared to rural background people, both in North and South India. But in our day-to-day practice, we are seeing many patients from rural background also that are having diabetes, and that those are not obese. But if because of pollution, because of genetic factors, because of those endocrine disruptors, they are also having these type of metabolic syndrome and diabetes. Now, if we talk about second risk factor, then obesity is one of the common risk factors that can cause metabolic syndrome and diabetes. And there are very few research that has been done in India with respect to obesity as a risk factor for these type of metabolic problems. Despite having lower overweight and obesity rates, India has a higher prevalence of diabetes compared to Western countries, suggesting that diabetes may occur at a much lower body mass index in Indians compared with Europeans. Previously, it was thought that only obese patients can have a diabetes. Only obese patients are having risk factors for diabetes. But nowadays, we can see we are seeing in our day-to-day practice that many patients are of lower BMI, are of thin build. Those are having uncontrolled diabetes, and main reason of this type of behavior, main reason of these type of uh, developing syndrome can be because of our genetic factors, because of our adiponectin behavior, and in this way we can say that higher BMI only is not a risk factor for diabetes. Uh, Furthermore, Indians are genetically predisposed to the development of coronary artery disease due to dyslipidemia and low levels of high density lipoproteins. These determinants make Indian more prone to the development of the complications of diabetes at an early age, that is 20 to 40 years, compared with Caucasians. And Caucasians having diabetes and their complication mainly above the age of 50 years. And this indicates that diabetes can be present in very young age in younger age patients in India. Now, third risk factor that we can say is high cholesterol and high blood pressure. If a person has high level of cholesterol, then the extra fat in the blood sticks to the walls of the blood vessels. Over time, this fat hardens and is known as plaque. And this hard plaque can block up the blood vessels, which make the space narrower and which leaves less space for blood to flow. And during when the time progresses, this narrowing space can cause thrombus formation, which can cause clot formation, which can cause stroke. If a blood clot breaks away, it can partially or completely block any arteries or veins. This can cause heart to deprive of oxygen and nutrients and subsequently lead to a heart attack. Additionally, high blood pressure due to the narrowing of the blood pressure puts extra strain on the blood vessels. Next slide. Now, how can we prevent the diabetes and their complications in diabetic patients? As we all know that the first risk factor is sedentary lifestyle, so we should avoid this type of behavior. We should try to be physically active, and current CDC guidelines also recommends a minimum of 150 minutes of moderate intensity aerobic exercise, and this moderate exercise includes brisk walking and swimming, or 75 minutes of vigorous intensity exercise each week. People should also consider doing muscle strengthening exercises. The second risk factor that is causing diabetic complication is overweight or obesity. So we should maintain a healthy weight. For people with excess weight, losing even a little can help reduce the risk of both high blood pressure and diabetes. National Heart, Lung and Blood Institute noted that a 3 to 5% loss of body weight can improve blood pressure readings. Next slide. We should have a healthy diet lifestyle. Dietary limitations, dietary patterns is very important to prevent any type of complication or to prevent of having metabolic syndrome, high cholesterol, blood pressure, and overall well-being. These healthy diet include fresh fruits and vegetables. We should have high fiber in our diet, including whole grains. We should avoid salt and sugar in our diet, and we should also avoid unhealthy fats like trans fats and animal fats. Now, smoking is a major risk factor for development of diabetes and its complication. Smoking is not only hazardous to the lung, but also it causes constriction of the blood vessels, which can increase blood pressure. And this increase in blood pressure increase the chances or increase the risk of formation of plaque, which can also increase blood pressure over time. Tobacco smoking can also increase risk of type 2 diabetes, and the smokers have higher risk of developing diabetic serious complications like kidney or heart failure, like retinopathy, which leads to blindness, poor blood flow, which leads to having infection and risk of foot or leg amputation, and peripheral neuropathy, which can cause nerve damage in arms and legs. Next slide. Now, what can be our treatment strategies for the diabetic patients? Uh, Initially, maximum most of the physicians try to start only medication for the diabetic patients, but we should firstly advise patients to having a good lifestyle and to avoid sedentary lifestyle, having a good diet, having tried to teach them to lose weight so that they can prevent uh, development of diabetes and metabolic syndrome. If diabetes already is there, then we can start early initiation of combination therapy, and this is an approach to achieve glycemic goals earlier and delay the deterioration of glycemic control with possible better preservation of beta cell function. Some of the novel medication therapy are DPP-4 inhibitors like SETA, Sexa, Lina, or Alogliptin, SGLT2 inhibitors like Cana, DAPA, and empagliflozin, GLP-1 receptor agonists like Dula or liraglutide. Next slide. Now, if we talk about combination of SGLT2 inhibitors and DPP-4 inhibitors, this is a fixed dose combination. And why this combination should be used? Because it is a safer, rapid, and rapid combination with and the benefit of this combination is that it provides sustained glycemic control. It improves both insulin resistance and beta cell function. It helps reduce reducing body weight and reducing blood pressure, and it helps reducing pill burden, and it is overall cost effective. And the mechanism of SGLT2 inhibitors, how they prevent hyperglycemia, how they lose weight is SGLT2 inhibitors mainly increase glucosuria from kidneys, and in this way it leads to decreased glucotoxicity, loss of weight, and decreased systemic blood pressure. Indirect pancreatic effects is there, in which SGLT2 inhibitors increase beta cell sensitivity and increase glucagon concentration. When we talk about DPP-4 inhibitors, the mechanism of DPP-4 inhibitor is it increases insulin secretion and it decreases glucagon concentration. And in intestine, because of its incretin effect, it increases concentration of GLP-1 and increase GIP concentration. GTP4 inhibitor is weight neutral. SGLT2 inhibitor is causing weight loss. So combination is better for those people who are having higher weight, who are obese, and having higher blood pressure and uncontrolled hyperglycemia. I think this is the last slide.
Thank you, Dr. Nikhit. Very good presentation and lots of questions coming from the audience. So you've been able to discuss not only prevention, but also management. But another way of looking at things is that whatever we do in the diabetes clinic, we are preventing disease. For primordial and primary prevention, we are trying to prevent diabetes. But when we give medicines like DPP4 inhibitor, SGLT2 inhibitor, even then what we are doing is secondary prevention. We are trying to prevent
Yes,
complications. Suppose the complication occurs, somebody does develop heart failure, somebody does develop CKD, even then these drugs are relevant. So if you choose a drug
yes,
which is helpful for both secondary and tertiary prevention, actually things become much easier for the patient. Many times patients don't understand what we are trying to do, and if we can use this talk of prevention with them, so prevention in the sense that you tell them that what we are doing when we are giving you an SGLT2 inhibitor is, it's not only that we are managing disease, we are preventing disease for you, then perhaps they will understand better, and we are promoting wellness for you if we can use that language. But sir, a question from the audience: what is the current status of primary prevention of type 2 diabetes? Does it work in practice?
yes. It's thank you, sir, for your excellent questions. Actually, primary prevention is very important for the prevention of diabetes because if diabetes has already occurred, then we can try to decrease chances of having complication. But if we try to prevent of having diabetes, then this is very beneficial for those patients. And for that, we should advise them to having a good lifestyle, or try to avoid junk foods, try to avoid stressful conditions, and in this way we can teach them of not having diabetes because diabetes previously it was known that diabetes is a non-reversible condition. But if we can try hard, if we can treat hard, if we can treat fast, then we can actually reverse the diabetes if we have caught them in early stage. So this is my way of uh, teaching those patients.
One more question is there a gender difference, gender bias? Will different or specific approaches be required for women, for men, for younger adults? Anything that that comes to your mind?
Yes, sir, definitely. Because in our society, females are not very educated, especially in rural areas, in uneducated areas. We should have tried to teach those females to avoid those sedentary lifestyles and to come to the clinic to follow our advice and regular checkup because these female patients are not in liberal condition to follow our advice, and this is more likely a social stigma that female patients are can't eat any tablets, or they should not reach to doctors. So we should try to avoid these type of things. And as far as age is concerned, yes, type 2 diabetes is nowadays have been seen in a younger patients, and they have uncontrolled diabetes and they are using insulin, and we should try to teach them also because uh, these type of younger patients are more focused on junk foods, are more in a stressful condition. So these factors are more likely to generate diabetic complications. So we should try to teach them that they should avoid these type of factors to avoid diabetic complications.
Do you face any challenge in the OPD when you have to prescribe an FDC, let us say an SGLT2 inhibitor containing combination or monotherapy? So, what is the counseling that goes into adding value to this prescription? What is the minimum counseling that should be done?
First of all, uh, the main factor that is preventing us to prescribe these fixed dose combination is cost. But nowadays, these combination are lowering their cost. But patients often ask why you prescribe those tablets. So we should tell them that you are having diabetes, you are obese person, you are having a cardiac condition, and you are having already have a higher BP. So these fixed dose combination have multiple effects, and they can treat you in a better way, so that not only diabetes but also your kidney will be improved, your heart will be improved, and your blood pressure and weight will be improved, so that overall you will have a good diabetic control.
Thank you, Dr. Nihit. Thanks for the very succinct and very practical explanations, things which make it easier for us to create a discussion and dialogue with our patients when we go back to the OPD. And I think that is the beauty of 4D. The discussion and dialogue about diabetes is presented in such a simple manner that you can very easily translate all the learning from these webinars into your practice. That is, I think, the beauty and the strength of the 4D series. With this, I'd like to thank Nihit once again for being with us. Thank you, sir, for sharing your
Thank you, sir.
expertise and your
Thank
experience, your
you.
time with us. We are grateful. And thank you to
Thank
everybody
you,
for
sir.
having logged in. I would also be lacking in my information, in my duty, if I do not appreciate the people behind the scenes, the team from Sun Pharma, the team. Batul is with us backstage today. Thank you for all the technical know-how that you bring into making this program a success. Thank you, everybody, and Jai Hind.